5 minutes and we'll start.
Yes, sir.
We'll wait for a few more minutes. Let
Yes.
people join.
8:35 को join करते फिर start करते हैं.
Yes, yes.
Yeah. पेशेंट आया है बैठने
So let's start. I think we can start at 35.
Yeah, so already 50 attendees, so we can start people. Yeah. So good evening, everyone. Welcome to this yet another edition of Neuromuscular Subsection meeting. And this meeting we have been doing every 2 months the last few years now. So today we have a very interesting presentation from PGI Chandigarh. It will be moderated by Dr. Ritushri. She is a associate professor in Department of Neurology at PGI Chandigarh, and the presentations will be done by two senior residents, Dr. Bhumika Goel and Dr. Tanya Banerjee. So let's get going. So Dr. Ritushri, you can start the proceedings. Yeah.
Thank you, sir. I would like to thank Indian Academy of Neurology Neuromuscular Subsection for inviting PGI for this subsection webinar session. So we are going to present two cases. Both the cases are like regular OPD cases. The first case is a rare etiology of neuropathy, and the second case will be like garden variety neuropathy, which we see daily with an uncommon presentation. So we'll start with the first case, which will be presented by Dr. Bhumika Goel. She is the third semester DM senior resident. So Bhumika, please start.
Thank you, ma'am. Good evening, everyone. Today I am going to present a case who came to PGI around 1.5 years back. He was a 38-year-old gentleman, police officer by occupation, hailing from Bihar. He came with 2 years history of...
Bhumika, can you make it in the
Slideshow.
full screen, slideshow full screen?
Is it visible now, sir?
No. Yes, now it is there.
So good evening, everyone. My patient is a 38-year-old gentleman who presented to us around 1.5 years back with the history of swelling of bilateral lower limb for 2 years, breathlessness for 1.5 years, and weakness of bilateral lower limb for 1.5 years. So his history started 2 years back with the swelling of bilateral lower limb, which initially started from the dorsum of feet, extended till knees, painless, used to aggravate after prolonged standing, and used to get relieved after taking rest or sleep. After around 6 months into the illness, he started having breathlessness. Initially used to have breathlessness only on exertion. However, in next 6 months, it aggravated in such a level that he was not able to mobilize even 100 meters without getting breathless. Along with breathlessness, he developed facial puffiness, which used to be more during the morning hours and used to get relieved as the day progresses. However, there was no history of decreased urine output or progeria. Around 9 months into the illness, he started having weakness of lower limb, which was proximal symmetrical weakness, gradually progressive such that he was requiring one person support over next 3 to 4 months. After around 3 months of proximal lower limb weakness, he started having weakness of bilateral lower limb, distal lower limb, in the form of slippage of slippers with knowledge and difficulty in navigating feet into slippers. I would like to highlight at this point of time, he did not have any sensory symptoms, no upper limb involvement, no truncal involvement. He had only bilateral lower limb, motor weakness, proximal followed by distal. On prompting, he gave the history of reduced libido and absence of nocturnal penile tumescence for last 1 year. So 1 year into the illness, he had consulted a local doctor where he received some treatment, and the details will be discussed in the subsequent slides. After treatment, all these uh, weakness and all the complaints had become static. However, he developed a new symptoms in the form of numbness and thickened skin sensation of bilateral soles and history of tingling sensation of dorsum of feet. There was no history of loss of appetite, loss of weight, night sweat, or any febrile illness. No history of joint pain, mouth ulcer, photosensitivity. There was no history of any addictions or high risk behavior, no history of CAM intake, and there was no significant family history. So this is the final history database. 38-year-old male presented with 2 years progressive history of swelling of bilateral lower limb followed by dyspnea, followed by bilateral lower limb weakness proximal followed by distal, had history of reduced libido, absence nocturnal penile tumescence, and from last 6 months having sensory complaint which was restricted to the bilateral soles. For these complaints, around 1 year before developing the sensory symptoms, he had consulted a local doctor who kept the diagnosis of possible connective tissue disorder, and he gave him methylprednisolone 1 gram for 5 days, followed by oral steroids. Steroids were tapered over next 3 months, and he was started on azathioprine. After receiving this treatment, his weakness had become static. However, he developed the sensory symptoms in bilateral lower limb. So coming to the localization of these symptoms, my patient had bilateral leg swelling plus periorbital puffiness plus breathlessness. In view of periorbital puffiness, I would like to consider renal as the first substrate. However, there was no history of progeria, no history of decreased urine output even after 2 years of history. Second possibility could be cardiac involvement. Again, there was no history of orthopnea, chest pain, or cough. Bilateral leg swelling can be explained by involvement of autonomic nervous system, autonomic neuropathy. However, because of periorbital puffiness and breathlessness, I have considered the systemic cause first and then the autonomic. Second symptom was weakness, which was restricted to the lower limbs, followed by numbness and paresthesias. I would like to mention that motor symptoms were out of proportion to the sensory symptoms, and they were restricted to the bilateral lower limbs only. So for the motor weakness, I would like to consider motor radicals, and for the numbness and paresthesia, the neuropathy. So my combined localization will be the polyradicular neuropathy. I would like to emphasize that this is not the typical polyradicular neuropathy which we see regularly, because again there was no upper limb involvement even after 1 year of starting of the weakness of lower limb. There was no cranial nerve involvement, and there were no even sensory symptoms in the upper limbs. The other possibility could be plexopathy, but from the beginning itself, patient has bilateral symmetrical weakness, and sensory complaints were very less as compared to motor complaints. Initially, patient had only motor weakness, so other anatomical localization could be muscle, anterior horn cells, or neuromuscular junction. However, because of sensory symptoms, we have not considered these possibilities. The next symptom was loss of nocturnal penile tumescence and reduced libido. So for this, I would like to consider hypogonadism. Loss of nocturnal penile tumescence can be explained by autonomic dysfunction also. However, because of reduced libido, I have considered hypogonadism as the first possibility. So my final substrates are polyradiculoneuropathy, anasarca, and hypogonadism. So what could be the possible etiologies? First, I have considered immune-mediated demyelinating neuropathy could be because of contacting 1 or Casper 1. The points in favor are patient being adult male, having symmetrical, rapidly progressive motor predominant weakness, and having renal involvement, probable renal involvement. The odd points were there was no tremors, there was no sensory ataxia. Second etiology could be connective tissue disease because there is multi-system involvement, patient having pedal edema, facial puffiness. Again, patient had predominantly motor involvement, minimal sensory. There was no history of ulcers, joint pains, Raynaud's or erythema of the skin. The third possibility could be paraproteinemia causing polyradiculoneuropathy, and pedal edema again favor the paraproteinemia. However, again, same thing, patient has very less sensory symptoms and there was lower limb restriction. The next possibility could be amyloidosis. However, autonom- however, there was no significant autonomic involvement, so we have kept it less likely. The other possibility which can include which can explain the polyradiculoneuropathy along with pedal edema is toxin-mediated neuropathy, but there was no history of any exposure or temporal association. The next could be infiltrative disorder, but patient did not complain of pain anytime during the history, and the involvement was symmetrical from the beginning itself. The other I have considered is paraneoplastic, other than hematological disorders, for example, anti-Hu mediated polyradiculoneuropathy. But the sensory symptoms were very less and it was motor predominant weakness, so that is odd for this. So let's proceed to the general physical examination. When we did the examination, the most prominent part during the examination was the hyperpigmentation of the skin. How we picked up because he was having hyperpigmentation of the soles and the palms also. When we asked him, he showed us photos where there was significant change in his complexion. So there was marked hyperpigmentation, which he had not complained to us initially. There was early graying of hair and some frontal balding. There was gynecomastia, which was confirmed on palpation. Patient had pedal edema, as we can see the slipper marks over the bilateral feet. There was no pallor, icterus, clubbing. There was no lymphadenopathy. CVS and respiratory examination was unremarkable, and there was no organomegaly. Coming to the neurological examination, he was conscious oriented and his higher mental function was normal. Cranial nerve examination was unremarkable except the bilateral grade 3 papilledema. On motor examination, his tone and bulk was normal in all 4 limbs. Upper limb power was 5 by 5, including the small muscles of the hand. The weakness in the lower limb was noted in the hip extension, knee flexion, and plantar flexion, which is in the radical fashion of S1. However, the ankle dorsiflexus were more weaker than the plantar flexion, and there was weakness of EHL and weakness of small muscles of feet also. So, because of that, I have considered the neuropathy. So, we have kept the possibility of polyradiculoneuropathy on the history, which I have confirmed on the examination. Deep tendon reflexes were absent in the all 4 limbs. I would like to highlight that patient did not have any involvement of the upper limbs during the history. However, reflexes were absent in the upper limbs also. Bilateral plantars were flexed. Sensory examination showed JPS and vibration sense were impaired at the bilateral gate rows. Rombox was absent. Touch pinprick temperature were preserved in all 4 limbs, and cerebral examination was normal. So what have I added after my examination? My patient is having bilateral grade 3 papilledema, diffuse skin involvement in the form of hyperpigmentation, gynecomastia, and I have confirmed polyradiculoneuropathy on examination. So does my possibilities change? No, still I would like to consider the same etiologies. However, I ruled out infiltrative as patient is having symmetrical involvement of bilateral lower limb. So let's take the help of investigation to reach the diagnosis. On nerve conduction study in NCS, snaps were NR in non-recordable in bilateral lower limb. However, there was involvement of the upper limb also in the form of decreased conduction velocity and decreased amplitude in the upper limb. In motor NCS, It was non-recordable in bilateral lower limb again, and conduction velocities were decreased in the demyelinating range. SSR was absent in bilateral lower limb. So on NCS, patient has sensory motor demyelinating polyneuropathy with small fiber involvement in bilateral lower limbs. On routine investigation, patient was found to have mild thrombocytosis, and there was total protein and albumin ratio was altered, so there was AG reversal. On CSF, there was albumin cytological dissociation. Malignant cytology was negative. As patient has gynecomastia, so we had went ahead with endocrine profile also. That showed subclinical hypothyroidism, decreased testosterone. There was increased ACTH and decreased cortisol levels. There was increased IGF-1 levels, and interleukin-6 levels were increased, which were marker of inflammation. No biopsy was done from the left dorsal ulnar cutaneous nerve, which was suggestive of chronic axonopathy. As one of my possibility was paraproteinemia, so myeloma workup was done. There was no M band, and even immunofixation did not show any specific Ig antibody. Serum kappa and lambda chains were elevated in significant values. However, the ratio was maintained because both were increased proportionately. Beta 2 microglobin was normal, and a myeloid fat pad biopsy was done, which came out to be negative. So how do we proceed further? What all I have added after my investigation now? Patient is having thrombocytosis, there is cytoalbuminological dissociation, NCS showing sensory motor, demyelinating polyneuropathy with small fiber involvement. On endocrine profile, there is subclinical hypothyroidism, decreased testosterone, increased ACTH, increased interleukin-6 levels. And on myeloma workup, there is increase in serum kappa and serum lambda chains. However, there was no M band on SPEP and UPEP. So what did we do? Because of involvement of, there was increase in serum kappa and lambda, we went ahead with the bone marrow biopsy. Flow cytometry showed 0.23 non-clonal plasma cells with kappa is to lambda ratio of 1:1, and bone marrow biopsy showed sheets of plasma cell diffusely positive for CD138. Again, we are stuck because this number of plasma cell does not qualify for the any non-plasma cell disk carriers. So what we did, we went ahead with skeletal survey and it came out to be negative. So what do we do now? We went ahead with PET scan. As we all can see, there is a lesion in the right ileum. It was FDG with lytic lesion with sclerotic margins and soft tissue component. So what did we do next? We went ahead with the biopsy, which was suggestive of plasmacytoma. And our final diagnosis was POEM syndrome with plasmacytoma. So what is this POEM syndrome? This term was coined by Bradwick in 1980. It's a rare paraneoplastic syndrome. And this acronym includes only few features of these syndromes. Acronym means polyradicular neuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes. When I say rare, how rare it is? Incidence of POEM syndrome is 3 per million people, and it consists only less than 1% of paraproteinemias. Coming to the diagnostic criteria, we have mandatory criteria, major criteria, and the minor criteria. Mandatory criteria is polyneuropathy and monoclonal plasma cell proliferative disorder. Major criteria are Kesselman disease, sclerotic bone lesion, and elevated VEGF levels. Minor criteria are organomegaly, extravascular volume overload, endocrinopathy, skin changes, papilledema, thrombocytosis, and polycythemia. To qualify for POEM syndrome, patients should have 2 mandatory criteria, 1 major criteria, and 1 out of 6 minor criteria. So when I say my patient is on POEM syndrome, does my patient qualify the criteria? Yes, my patient had polyneuropathy. Patient has monoclonal plasma cell proliferative disorder. He had a lesion on the PET scan, which was sclerotic. Patient had volume overload in the form of pidal edema, facial puffiness, endocrinopathy were there, skin changes were there, papilledema was there, and thrombocytosis were there. One thing I want to highlight is in endocrinopathy, diabetes and only hypothyroidism does not qualify for the endocrinopathy because of high prevalence in the general population. So what is the pathogenesis behind this syndrome? The main culprit is vascular endothelial growth factor. These plasma cells which are proliferating, they secrete vascular endothelial growth factor. As the name suggests, it causes the neoangiogenesis and the growth of the vessels, which makes this barrier leaky, blood now barrier leaky, and there is accumulation of immunoglobulins, light chains, and cytokines, which lead to nerve damage, leads to ischemia, which leads to increase in hypoxia-induced factor 1 alpha increase, and which further leads to increase in interleukin 6 level, and which leads to increase in VEGF level. So this cycle keeps on going. Again, VEGF increases the procoagulant state in the blood. It crosses all the barriers and goes to all the organs, multiple organs, and lead to the destructions and lead to multiple organ involvement. So when I told that yes, my patient qualified the criteria for POEMS. One was patient was having polyradiculoneuropathy. But what about the plasma cell disorder? Does plasmacytoma qualifies under POEMS or not? So in typical POEMS syndrome, it is found to be IgA monoclonal gammopathy and lambda restricted. However, my patient had kappa and lambda in the same ratio. But these are the various plasma cell disc areas which are considered under POEMS. These are osteosclerotic myeloma or osteosclerotic plasmacytoma. Next is MGUS, then Castleman disease, multiple myeloma, and Waldenstrom microglobulinemia. So to call it plasma cell disorder for POEMS, patient have to have one of these. What about the bone lesion? My patient had lytic lesion with osteosclerotic margins. So what all bone lesions can be considered under POEMS? First, most typical is the osteosclerotic lesion. Second is mixed lytic and sclerotic lesion. And third is a blastic lesion. I would like to highlight that purely lytic lesion and diffuse osteopenia does not qualify for POEMS. So this solitary plasmacytoma, it consists around 3 to 5% of all plasma cell neoplasm. And association of plasmacytoma with POEMS is 33%. So next is skin lesions. My patient only had hyperpigmentation. Still I told, yes, my patient qualified the diagnosis. Again, the same thing. Yes, hyperpigmentation is the most common finding seen in POEMS syndrome. Next is coarse long hair over the extremities. Third is hemangiomas, acrocyanosis. Fourth is skin thickening, and there can be nail involvement in the form of clubbing and white nails. This picture I have taken from the article. This is not my patient's picture. It is showing the acrocyanosis, the clubbing, and the white shiny nails. When we checked retrospectively, even my patient had mild clubbing and there was whitening of the nails. So how did we treat our patient? According to the literature, if patient is having plasmacytoma or if there is only localized involvement, if there is less than 3 lesions on the PET scan, then we can go ahead with localized radiotherapy. If patient is having systemic involvement of there are more lesions, more than 3 lesions, then we have to go ahead with systemic therapy, and we have to do extensive assessment every 3 to 6 months. What do I mean by extensive assessment? It includes VEGF levels if there are no financial constraint. We could not do in our patient because of the financial constraint. Second is PET scan. For example, my patient has plasmacytoma, so I have to repeat the PET scan and see what happened to the lesions. Third is clinical. How is the progression of the patient clinically? In our patient, we have given localized radiotherapy, and on follow-up, after around 6 months, the edema had resolved completely, sensory symptoms had reduced, he was able to walk without support, and hyperpigmentation has resolved significantly. The PET scan, which was done after 9 months, showed right iliac lesion had disappeared. What if my patient wouldn't have improved with radiotherapy? What are the other options? Then we have to take help of our hematology colleagues, and we have to frame a regimen for the disease like multiple myeloma or any plasma cell disc areas. I just want to highlight that stem cell transplantation has significant improvement in patients of POEMS syndrome. So there are few electrodiagnostic findings which can help us in differentiating POEMS from CIDP. Conduction block are much less frequent in POEMS. That means POEMS is having uniform demyelination as compared to CIDP. SNAPs and CMAPs of lower limbs are disproportionately more severely affected in POEMS. As seen in my patient also, SNAPs and CMAPs are non-recordable in bilateral lower limbs. And axonal loss is more prominent in POEMS. So what are the take-home messages? In any case of neuropathy, associated symptoms are key to narrowing the differentials. Detailed history and focused examination are essential for identifying the underlying cause. Any case of CIDP who is refractory to treatment, paraproteinemia should be considered. Thank you.
Thank you, Bhumika.
Thank you, ma'am.
Excellent case. I think it was so excellently worked up and presented, Dr. Bhumika.
Thank you, sir.
Fantastic presentation.
Nicely presented.
Yes, Vishnu, you have a special, I think, expertise in poem syndrome. I think
I think
you
sir
need your
likes
comments.
poems a lot, so if he could add few points.
No,
Yes, yes.
no. How expensive is veggie? That's what I want to ask.
So I think it's 5,000 or 6,000 rupees.
Yeah, something around 6,000. I
Yeah,
mean,
5,000.
so it's not. I mean, something if that one investigation can change from sometimes the whole management pattern, no? So in the sense, in one way or the other. So because once you develop these features, and it's in atypical features, especially with hyperpigmentation and endocrine abnormalities, one investigation can almost clinch you the diagnosis at that point of time. That's one. Second thing I would say is, I mean, we have currently have two poems admitted in the ward, so we've been asking questions to the resident. What are the differentiating features between something which I was asking? So one feature, electrophysiologically, one more feature which I think I told in the last poem's presentation also, other than the three she mentioned, is the sometimes you leak the intermediate segment affected. No, especially if you are involving in the upper limbs or the lower limb, you get more than the distal latency prolonged, you will get more of the conduction velocity will be reduced, more of intermediate segment involving more than the distal latency prolonged. Sometimes that you usually in CIDP you will get a proper distal latency prolonged, very high distal latency prolonged. Poems usually more of a conduction velocity reduction more than the distal latency prolongation. Somehow, I don't know the exact mechanism. So they say that it is more of involvement of the intermediate segment than the distal segment involvement. That's something which is interesting. And and finally, so they got poems is should be managed by, I mean, this is for somebody who is listening for the first time. Poems you should manage with a hematologist or a hemato-oncologist. So we don't try to treat poems by yourself. So PJ has got a great hematology department, so they don't have to they don't have a problem with that. But if at all, if it's not there, you should chemo. If patient requires a proper systemic therapy, or even if it's a local therapy into that case. And it's very rewarding to treat poems, and it's in poems it is mainly the patients. The patient should have the patients, and the clinician also should have the patients. Sometimes improvement occurs little late, so don't get disheartened by the initial little delay in recovery that occurs in patients. Sometimes you get, even if a little late, patient recovers. Sometimes it takes more time than what a usual CIDP takes time to recover.
This patient also, sir, he was not ready to even was not ready to admit because he was being evaluated in the northern eastern India. Uh,
Mhm.
he has gone to many hospitals, so he thought that he'll never be treated, he'll never recover. So, but we actually convinced him in the OPD to get
Mhm.
admitted so that we can reach the diagnosis.
I always have a belief that all CIDPs VEGF should be done. I mean, even if it is there. So in that, it is more cost effective to do. So even if in 100 cases of CIDP, you picked five poems, the amount of IVIGs and other alternative treatments that we give for in a poem, because it will, those five treatment, for example, especially when patient doesn't pay, if it is systematic, if it's like a government setting or a in UK setting like NHS pays for all the money, the amount of money you can save from this five patients can actually pay for the VEGF for all the other 95 CADP patients. Something of that sort. That's for another day's discussion. So I think there are a couple of questions in the Q&A sessions. That if you Q&A, so if you can, especially somebody had asked for a small fiber neuropathy. How commonly is it in poems?
So small fiber neuropathy, she kept telling because the patient kept complaining of small fiber symptoms like he has pain. He even after recovery now also he has been on pregabalin and the power has improved, everything has improved, but he says that he had slight burning in his lower lip. So that is why we kept other possibility also like toxins and some infiltration, but he had already had MRI done, so we ruled it out in the beginning on. So in poems, large fiber neuropathy is more common as compared to the small fiber neuropathy. As we have not seen many poems, so I cannot tell the incidence and prevalence as of now. Dr.
And
Rakesh, sir, anything you?
Yeah, I mean, it is quite common, in poems, the pain is often very, very common, and it may look like a small fiber neuropathy. Almost, I think 30% of patients of poems, as per the literature, I have also not seen many, but they say it can look like quite a bit of a pain, it may look like a small fiber pain. What do you think, Vishnu?
yeah, I think so. And the literature wise, I also don't know. I'll have to look it up. How common is the neuropathy, the small fiber neuropathy part in this? But pain is a very significant symptom. I think that's yeah. So if you don't have any more
And
questions,
there was one
Yeah.
point.
yeah,
There was one point, Vishnu. They
yeah,
have said that the VEGF levels can be normal or it can fall if patient has received steroids earlier. Now these patients are refractory CIDP. Somebody must have used steroids earlier before they ultimately are diagnosed. Sometimes the VEGF can, I mean, as per the literature, the VEGF can be normal. I mean,
yeah,
but
yeah.
yes,
So
it's
so
the most
ultimately,
sensitive.
yeah, it
Yes,
doesn't
yes.
have a. I mean, it doesn't have 100% sense because that is only one of the criteria. I mean, it's not a mandatory criteria to be having. But since VEGF has a pathogenic role, but somehow one thing is that anti-VEGF therapy didn't make much. They tried to treat. I mean, they tried to do anti-VEGF therapy in these poems, which was not very successful. So that may be the so one of the things of VEGF may not be the only reason why this is happening, but still as a biomarker, it's not very 100% in every patient in that case.
We had this IL-6 elevated that
Mhm.
I don't know why we did it, but
No,
it
no. IL-6 you do it
is.
for to rule out Castleman's, right? So in case of because if you have a lymphadenopathy, poems itself can have lymphadenopathy, and if you have Castleman's, your management strategy will slightly differ on this is one. So if you have, for example, if you have lymph nodes and the lymph nodes are not very florid that you see in this one, there is always a question whether you should do biopsy of lymph node or not. Okay, so if you have VEGF, you have everything, all your criteria of poems is satisfying and okay, if you are likely to get lymphadenopathy and organomegaly in poems, should we still go ahead with the lymph node biopsy or not? So sometimes if the IL-6 is elevated, and that will help you that okay, it's a Castleman, likely to be Castleman, do a biopsy and biopsy that shows a Castleman's. The management strategy will slightly differ if it is a multicentric Castleman versus there is a garden variety poem syndrome. The duration of treatment, chemo, those things and all will slightly differ. In that case, IL-6 might help.
So
A few more questions, if you can take. Why was Casper and contacting done? Was paraneuropathy or DD here?
so
Somebody asked.
no, sir, we did not do Casper and contacting. We kept it as a possibility. So
Okay.
in between the workup for this, all these came and PET was done. So that is why we did not go ahead with that. And
Yeah.
confusing point about myeloma workup was that the ratio was normal. It was not decrease, not increase. So that was confusing. And the bone marrow, which was done also was like normal. So if the plasmacytoma was not found, so we would have we would be confused that the whatever polyclonal gammopathy which is happening is contributing to the neuropathy or not. So luckily we got plasmacytoma and then we did the biopsy and got plasma. So there is one more question.
Yeah.
What are the other causes of pedal edema? I think in CIDP you can get pedal edema because of patient lying down, wheelchair bound, bedridden. So you can get pedal edema. And kappa and lambda light chain can be falsely elevated in fluid retention states like nephrotic, cardiac failure, and cirrhosis. We ruled it out. And what is the specificity of VEGF in diagnostic poems in any case of CIDP? Can it lead to false positive diagnosis of poems? So, in poems, you have to fulfill the criteria. So, if only neuropathy is there and only VEGF is there, I don't think we will go ahead and treat it like poems. See, we have to investigate it fully. You have to have the syndromic diagnosis, and then you will name it as poem because it's a constellation of symptoms which lead on to the diagnosis of the poems. And the last question somebody has asked, Crow Fukase's name has gone or not. Some people still call poem syndrome by this name, and there are other names also. So, but the commonest name which everyone calls poems is by the poem syndrome.
And then, I mean, I just want to clarify. Don't get into the impression that I want to do VEGF in all CIDP cases. So what I was thinking was telling you about the cost effectiveness of doing VEGF in all cases of CIDP. If
There was a
somebody pays for
study
it.
also, sir.
Yeah,
There
yeah.
was a
So it's
study which I think you must have read it.
yeah. So if you I mean, it makes sense also. No, if for example, if first line treatment for CIDP is IVIG in a setup in for example in UK, if all CIDP will get IVIG free of cost from the government, and if you make a diagnosis of you miss 5 poem syndrome and you treat them with IVIG, the cost, I mean, it's monthly IVIG or 6 months or something, and then the cost of IVIG for this 5 patients for 6 months, that will easily cover the VEGF cost for the 100 CIDP patients. So if VEGF is elevated, at least you get some clue towards further working up. You're not going to diagnose poems based on VEGF. At least with the very high elevation of VEGF, you look for the other criteria for poems. Somebody who a GP who is managing or referring patients will be able to see. In that setup, I was telling about. I'm not saying about every CIDP should undergo VEGF. I think we can go to the next case where this
Yes.
crossing 9 o'clock. Yeah.
Okay. Okay. So the second case will be presented by Dr. Tanya. Tanya, please share your screen. So Dr. Tanya Banerjee is from Kolkata, and she is in the fourth semester as DM student in PJ. Please go ahead, Tanya.
Good morning, good evening, everyone. Today I'll be presenting a case of CIDP. It's a very typical case which we see every day in our OPDs. However, towards the later stages of her disease, she had a twist in her story. So let's jump right into the case. My patient, a 55-year-old lady resident of Delhi, she presented with complaint of recurrent episodes of sensory disturbances of all four limbs associated with weakness since 2003, when she was 32 years of age. In March 2003, she had complaints of bilateral lower limb numbness and tingling, followed by weakness over a period of 2 months. On examination, she had wasting and weakness of lower extremities and small muscles of the hand, generalized areflexia, and glove and stocking pattern sensory loss. Her NCS at that time was documented as sensory motor demyelinating polyneuropathy, workup for vasculitis and multiple myeloma, ANA, ANCA, ROLA, SPEP, UPEP were negative. Nerve biopsy showed focal segmental demyelination with relative preservation of axons. She was managed with pulse methylprednisolone followed by oral steroids tapered slowly over the next 1 year, and she improved completely to normal. Because she had a very long history with multiple relapses, I have made a timeline which makes it easier to follow the complaints. As we can see, the blue rectangles represent her complaints, while the upper part of the graph represents her treatments which she has received over the years. So the blue line here represents the oral the steroids. So in March 2003, she was given pulse methylprednisolone. Steroids were tapered, and as we can see in June 2004, as the steroids were tapered up to 5 milligram per day. After 1 month of tapering steroids to 5 milligram per day, she had another episode of sensory motor disturbances. This time, she was again given methylprednisolone 1 gram, followed by an oral steroid slowly tapered. And at this time, azathioprine was also started in August, which was increased up to 150 milligram per day in September. After that, in August of 2004, her steroids were stopped. Few months after stopping the steroids, in February 2005, she again developed similar complaints of sensory motor disturbances. And this time she was again given methylprednisolone pulse, and azathioprine was continued as immunomodulation. Oral steroids were slowly tapered, however, she became lost to follow up between 2005 and 2010. She self-discontinued azathioprine sometime in 2009. However, oral steroids she continued to take at 10 mg or 5 mg because she reported reduce steroid dose or completely stop it, she had recurrence of tingling numbness in her palms and soles. In 2010, her story changed. She had complaints of headache with occasional vomiting and transient visual obscurations. At this time, she was evaluated outside, where her MRI brain was done, which was reported as normal. MRI LS spine and abdomen had been done, which was reported as plexiform neurofibroma involving bilateral lumbosacral plexus. CSF study had been done at that time, which showed 5 cells, protein of 487, with normal sugar of 73, with significant albuminocytological dissociation. CSF AFB, gene expert, and Cryptola were negative. However, she had been given empirical ATT for 6 months at this time. The MRI films of this time are not available with us at present. From May 2010 to 2014, she did not develop any further complaints of sensory motor disturbances. She was continued on oral prednisolone at 5 mg per day. However, her headache remained persistent. In June 2014, she developed new complaints along with the headache of diminution of vision of both eyes. Visual acuity was 6/9 bilaterally, with bilateral papilledema and visual field showing bilateral enlarged blind spot. At this time, she was evaluated outside. Possibility of IIH was considered and prednisolone was stopped. MRI and further treatment records of this time are also not available with us. In June 2014, her oral steroids had been stopped. 3 months after that, again in September 2014, she developed a severe episode of sensory motor quadriparesis. At this time, she was given pulse methylprednisolone for 5 days and azathioprine was restarted, which was slowly increased up to 150 mg per day, as we can see here. After that, she again became lost to follow-up between 2014 to 2017. She self-discontinued azathioprine around sometime in 2016, and because of recurrent boils and furuncles, and because she did not have any further complaints of sensory disturbances, she discontinued oral steroids by herself at the end of 2016. In May 2017, she again had a recurrent complaint of severe episode of sensory motor quadriparesis. At this time, she was again evaluated, and we have an NCS report of that time where we can see clear-cut demyelinating range, distal latency, as well as nerve conduction velocities in her upper limb as well as lower limb nerves. So at this time, in May 2017, she was again given pulse methylprednisolone, and azathioprine was also restarted and increased up to 150 milligram per day, which she continued to take. Oral steroids were tapered slowly by September 2017 up to 5 milligram per day prednisolone, and she remained compliant to treatment this time. However, she continued to have persistent headache during all this time, and despite being compliant to medication, in 2019 March, she had another episode of sensory motor quadriparesis, which was severe. This time, apart from methylprednisolone pulse, she was also given IVIG, which was repeated 4 times between March 2019 to August 2019. However, this time she did not improve fully, although there was improvement, but at this time she required 1 stick support to ambulate. Azathioprine, she discontinued in sometime in 2000. Again, she became lost to follow-up after 2019. And because she did not have any further symptoms and there was no improvement, no worsening, she stopped azathioprine by herself in 2020, as well as oral steroids were stopped. She does not report any further complaints during this time till 2023 February, when she developed worsening headache with seizures and altered mental sensorium over 3 days without any history of fever. She was admitted outside. Neuroimaging had been done, which showed hydrocephalus with periventricular ooze and no leptomeningeal enhancement. This is the MRI picture at this time, and we can see how much the lateral ventricles and the temporal horns are fully dilated with a lot of periventricular oozing. She underwent EVD on 15th of February, where the CSF again showed albuminocytological dissociation, 3 cells with 65 protein and 50 glucose. Post-EVD, she showed significant improvement in her sensorium. So VP shunting was done on 20th Feb, and her sensorium improved completely to normal. After this, her headache, which had been persisting since 2010, completely resolved. This is the MRI post-shunting, where we can see complete resolution of the hydrocephalus. At this time, she was found, after her sensorium improved to normal, she was found to be bedbound due to lower limb weakness. Prior to this, she had been ambulatory with one stick support. At this time, IVIG 2 gram per kg was given over 5 days in February 2023, after which she started walking with walker support by March 2023. IVIG was again repeated in April, and after this, the patient remained ambulatory with walker support for some time. However, and at this time in April, she was because she was also started on mycophenolate mofetil, which was slowly increased up to 2 gram per day. Despite compliance to mycophenolate mofetil, she had an worsening weakness by September 2023, where she became wheelchair bound, and rituximab was given at this time, 1 gram, repeated after 14 days. She again improved somewhat, able to walk with walker support. However, because of financial constraints, she could not continue with rituximab. So in March 2024, cyclophosphamide was started for her. But despite after starting cyclophosphamide, she developed cytopenias, so it could not be repeated till July. She received a second dose, but by this time she had worsening weakness and had become wheelchair bound, in which condition she presented to us in September 2024 for a second evaluation, for a second opinion. There was no history of any suggestive of any autonomic dysfunction. There was no history suggestive of any CTD features, no history of skeletal deformities or skin changes. And she did not have any comorbidities except type 2 diabetes, which she had developed over the last 2 years, which was well controlled. There was no significant family history. She consumed a mixed diet. There was no addiction with normal bladder, bowel, and sleep habits. On clinical examination, we had found mild pallor, pedal edema, thickened peripheral nerves, no skeletal or skin changes, and no neurocutaneous markers. Best corrected visual acuity was 6/9 bilaterally. Fundus showed blurring of nasal margin bilaterally. Bifacial weakness was noted. There was no jaw, tongue, or bulbar weakness. There was wasting of all 4 limbs, predominantly distal. There was no fasciculations. Bilateral upper limb had normal tone, but hypotonia in bilateral lower limbs. Upper limb proximal power was 4/5, distal wrist was 5/5, but weak small muscles of hand. Bilateral lower limb proximally at the hip was 3/5, distally at the ankle was 0/5, and neck flexion was also weak. All deep tendon reflexes were absent, and sensory examination showed glove and stocking pattern sensory loss. So coming to the localization, on substrate analysis in her case, she had recurrent episodes of large fiber polyradiculoneuropathy. Now, coming to the etiology of what can be the cause, since we have seen till now that it was a very steroid responsive disease, and as soon as steroids were stopped, the symptoms used to recur. So the most likely diagnosis was, in our case, was an immune mediated chronic inflammatory demyelinating polyneuropathy. However, secondary causes which could be considered are monoclonal gammopathy associated, inflammatory, connective tissue disease associated, sarcoidosis, hepatitis B/C associated, vasculitis associated, confluent neuropathy. But the odd point in our case was the presence of papilledema, the presence of headache, and the history of hydrocephalus which she had, for which she had been shunted. So let us try to knit the things together. CIDP with papilledema can be seen in cases of paraproteinemias, where the CSF proteins are very high, or toxin-induced neuropathies may have papilledema. However, these still do not explain why the headache was there. So what was the headache about? For the headache was associated with vomiting, transient visual obscurations, and papilledema. So it was definitely a raised intracranial pressure headache. We also had evidence of hydrocephalus, which resolved, and headache, which resolved completely after the shunting. So there is no doubt it was a raised intracranial pressure headache. But is it a separate pathology going along with the CIDP, or can we link the two together? So considering all these things, one possibility could be chronic infections, but considering the long duration of disease, no associated symptoms, steroid responsiveness, and no worsening despite being on steroids without any other therapy. So I think we ruled out this possibility as less likely. Another possibility could be some malignancy. However, again, such a long duration without any worsening and no associated B symptoms, no weight loss, this possibility was also considered to be less likely. Another possibility for the raised intracranial tension, which we considered, was whether there was some distal block in the CSF flow. So, with this hypothesis and background, we went into the investigations, we repeated them. So, routine lab investigations were all found to be within normal limits. The nerve conduction study showed a sensory motor demyelinating polyneuropathy. Vasculitis workup and workup for multiple myeloma were all repeated, which all came to be negative. For diabetes, her HbA1c was found to be 5%. And we also did an FDG PET, which did not show any abnormal hypermetabolism suggestive of any underlying malignancy. So, with this background, because of our hypothesis of distal obstruction of CSF flow, we went ahead with MRI screening of her lumbosacral plexus and spine. To our surprise, we found bulbous tumorous-like enlargement of the lumbosacral spinal nerve roots. As we can see, these are so thickened and so enlarged that they are easily confused with neurofibromas. Any neuroradiologist who will see this, the first thing he will say is the patient suffering from neurofibromatosis. So, although there are many other conditions which cause hypertrophied nerve roots, neurofibroma like lymphoma, and amyloidosis, all of these can happen, but CIDP should also be considered as one of the causes for this enlarged thickened roots. Then we went ahead with screening for the cervical spine as well, to see for the nerve for thickening of the nerve roots in other segments of the spine. So, to our surprise, in the cervical segment as well, the cervical spinal nerve roots are also so thickened and so enlarged, with tumorous-like enlargements affecting not only the cervical spinal nerve roots, as we can see here. These are the intercostal nerves which are also showing these thickenings. And these are the cranial nerve, the lower cranial nerve and 10 nerves, which are also showing the thickening. I have the magnified image in subsequent slide. This is the axial section of the thoracic spine, which is showing the intercostal nerve root thickening. And in the right side image, this is the trigeminal nerve. And this is the thickened brachial plexus. As we can see here, these are the brachial plexus nerve roots, which are so thickened and enlarged. And this is the thickened trigeminal nerve. As we can see, a nice mustache being formed here. And this is the enlarged image of the same, showing the thickened trigeminal nerves and the thickened 9th and 10th nerves. So, our unit's final diagnosis was CIDP with pseudo-Frohn syndrome, that is CSF flow obstruction due to the hypertrophied nerve roots. So, we went ahead and did a literature review of similar cases. And we know that spinal root and plexus hypertrophy in CIDP is a known thing which has been described since long back. The first reported series, an article published in Brain in 1999, a series of 14 patients with CIDP where MRI was performed, and they found that hypertrophy of the cervical roots and plexus in 8 cases, 6 of whom also had hypertrophy of the lumbar plexus. And they concluded that it is seen more particularly in cases of CIDP of a long duration. So it is a known thing that hypertrophy is there, but the extent of hypertrophy which can occur, sometimes they may mimic neurofibromatosis as well, as in our case, which was previously reported as plexiform neurofibroma of the lumbosacral nerves. So we found another case report, which was reported by Pytel P, where antemortem they thought that it was a neurofibromatosis. Later on, when they did an autopsy, 15 years after the onset of her symptoms, it revealed hypertrophic radiculopathy due to CIDP on biopsy, without any evidence of neurofibromatosis. So these are there were some other articles which were showing the characteristic MRI features of CIDP. I have put up some of the images. We can see the nerve roots are thickened and enlarged in these cases as well. However, the extent of hypertrophy which we saw in our case was out of proportion to anything which was reported previously. By Dilkar sir in an article as a neurology in 2015. So, hello, am I audible?
Yes, now you're audible. In between, your net is going. Otherwise, you're audible. Okay, please check your net.
Yes, ma'am.
Please continue.
So the mustache sign has been reported previously. It has hypertrophic trigeminal nerves. The left is a picture in a patient of CIDP, and the right is a picture of the hypertrophic trigeminal nerves in a patient of neurofibromatosis. So sometimes because of these hypertrophic nerve roots, they are so enlarged and so thickened that they cause some rare complications, like spinal cord compression has been reported with these nerve roots. Also, lumbar spinal canal stenosis has been reported, for which surgeries have also been done, as we can see from these case reports. Apart from that, hydrocephalus is one of the rarest of the rare presentations of these hypertrophic nerve roots, which we saw in our case. I found only one other case which reported that by Iwasaki et al. In 2020, where similar to our case, there was a CIDP with hydrocephalus, which presented with progressive dementia, which improved completely with steroids, immunotherapy, and VP shunting. Although the exact prevalence of intracranial hypertension, papilledema, or hydrocephalus in CIDP is not known, these are considered to be rare complications which are noted in only case reports or small case series. This was a literature which was done here also. Papilledema, although more relatively common, hydrocephalus reported in only one other case of recurrent GBS. All of these cases had significant albuminos, and in this case also we don't have the MRI data of the hypertrophic nerve roots, as it was a case of 1966. The MRI was not available. In all these cases, albuminocytological dissociation was very significant, and all of them improved with immunotherapy. And the other theories to explain the cause of raised ICT and CIDP have been proposed, apart from the swollen nerve roots causing CSF flow obstruction, is excessive CSF protein, which impede the CSF reabsorption at the arachnoid villi, and elevated CSF inflammatory markers causing immune-mediated inflammation over a long duration. So the take-home message is that hydrocephalus may be a rare complication of CIDP. Not all plexiform nerve root enlargements are neurofibromas, and that Occam's razor does hold true more often than not. We should try to explain all the symptoms of a patient with one diagnosis. Thank you.
Yeah, fantastic case, Dr. Tanya.
Yes.
And such a rare and odd, manifestation of a common disease. I mean, it can sometimes confuse you whether you're dealing with the
Yes.
lower motor neuron or upper motor neuron lesions, hydrocephalus and CIDPs. But
Yes.
how common it is, to get a
Yes.
hydrocephalus, and I mean papilledema, it is mentioned in the literature to be there in patients of CIDP. But hydrocephalus, as you mentioned, it's a very rare presentation.
Yes, sir.
Sir, I found only one other reported case in CIDP, which was reported in 2020 from Japan.
Hydrocephalus due to the spinal block, right?
Yeah.
Yes, sir. Because of the hypertrophic nerve roots, which is causing a pseudo-Freund's-like thing,
Yeah.
impeding the CSF
What is
flow
the
obstruction.
age of the patient?
Sir, currently she is 55. Her symptoms had started when she was 32 years of age.
Yeah. The only thing is, the more, what I think is the more the relapses patient occur, the regeneration, hypertrophy, the relapses, these are things are usually seen in patients with chronic relapses, multiple relapses occurring in those, whatever is saying, I mean, that may be the cause which causing the more hypertrophies, okay, which is regeneration happening, remyelination and demyelination happening, which causes the disease. The only thing which I would like to say is that if you have one thing is that you should rule out a genetic neuropathy also. Sometimes, CMT can have coexisted with the CIDP. Both patients can have both. So sometimes if we don't usually do root study in a CMT patient, a genetically proven CMT. We don't. If you actually do a CMT one, a chronic CMT one at the age of somebody with the age of 55 or 60 years, sometimes you do an imaging in of the root and plexus. Sometimes you can feel a similar picture in those this one. And in fact, there have been cases where there have been a CMT one, they have to do a cardiac decompression, spinal cord decompression to just help because of the so much of hypertrophy compressing onto those things. So that is also one possibility. But this is something very interesting thing. CIDP, which we all know, as Ritu told, there's a twist in the tail in the final length. Very interesting case.
Yes.
Yeah. Yes.
Sir, actually, hereditary also we had
Another
considered, but because it was so much steroid responsive, so like
No, I'm not saying it a pure
But
hereditary
it's telling
neuropathy.
coexisting.
Sometimes
Sir,
coexist. Sometimes
Tanya,
patients,
coexist.
coexist.
Actually, when we discussed this case in the round, sir, we actually planned it, but patient does not have any money for all these years. She has spent everything in the house, so that is why she is on cyclophosphamide. She did not. We did Plex also this time. The distal weakness in lower limb is now not improving. The upper limb has partial improvement. Now she is static. At least she is static. So what we wanted to show that this much enlarged nerves we have never seen, the trigeminal, the 9th, 10th, and we also have the ultrasound of the peripheral nerve. They were thickened like thick nerves. So that's what we wanted to show.
One point in your case was that despite being such a steroid responsive, over the years she never went into a true remission, despite being on steroids and IVIGs. Maybe probably it was being withdrawn very rapidly, because this is a very classical CIDP, which you put them on chronic steroids. The chances of inducing a true kind of remission is quite high, around 60-70% will go into a remission. But
So the
somehow this
first
patient
few,
never went. 20 years
sir,
have passed.
so the first few attacks she had achieved baseline, like 2000, Tanya, the first
Yes,
four
ma'am.
attacks which you show, she had the
Yes.
baseline, but then the progression started, and she was
Started.
actually lost to follow up in between, and then she started accumulating the disability actually.
Correct. Can we take some questions, Dr. Ritushri?
Yes, yes, sir. Yeah. There are comments, sir. I think IgG4, we have done IgG4, it was normal. And I think it has not been shown in the report. And the other thing is CIDP can cause raised ICP due to high CSF. Yes, it can cause. So there are no questions as well.
Yeah. What is the evidence of rituximab in a refractory CIDPs like this? Literature doesn't support that well, I mean, unlike the other conditions where rituximab really helps, somehow in patients of refractory CIDP, it has not shown a great kind of benefit.
Yes.
Even I think cyclos, I mean, there is some evidence of, I think, bone marrow transplantation, where they have said that patients who have such chronic and, badly relapsing CIDPs, bone marrow transplantation has shown some good promise.
So CAR T cell therapy is coming in all the
That is,
diseases. I think we can try that in few patients and see the results. So
I mean, sub-Q IgG, I mean, of course, cost is a limiting factor, but sub-Q IgG is there.
she actually this time we have given IVIG, I think 2 gram per day per kg for a induction dose, and then we did maintenance also for 2 months. But she did not show any improvement. But she became static. That was the only thing. But along with that, we were also given cyclophosphamide. So we don't know.
Yep.
I mean, another drawback of using IVIGs as a regular pattern in patients of CIDP, it is said that once on IVIG, always on IVIG. You will not be able to withdraw the IVIG. Unlike they have shown that steroids being cheaper and very useful for our kind of patients, it is much better than IVIG in chances of inducing a true remission.
I think most of the other
Other countries, they will go away from us.
Steroids. But evidence-wise, it is shown that steroids are better immunosuppressors than IVIGs. Yes, Vishnu. Yes.
Yeah, so this is the thing is that most of the cases CIDP, unlike other immunological conditions in neurology, CIDP is sometimes clinically it's easy to say, but it is sometimes so much of mixed picture, no? Because sometimes the diagnosis of CIDP itself is sometimes questionable in many cases, whether it's actually CIDP or not this case. Actually, when we rule out CIDP as such, because we are relying it on most of an electrophysiological criteria. We are on the clinical criteria. So there is no single investigations to do. So always those conditions are also there. Once we say that okay, it's then a lot of CIDPs are associated with myelomas, all those conditions. All so if you get a pure CIDP with nothing or no paraproteinemia, nothing is there. Now we are talking about refractory CIDP in those cases, right? Without anything else, without not responding. Again, it comes down to even to a smaller entity in that sense. And rituximab, and for us it is a panacea for most of the it's like a final comment for Ramban for a lot of many conditions in it. But I mean, pathogenesis of CIDP involves more than anti-CD9, CD20, and anti-CD19 also. So and a lot of other things. I think more of complement pathways are coming up. I think in most other neuroimmunological conditions now, ultimately complement pathway is coming up in GBS also. It will it will come up in trials will come up in CADP also. Let's see. Mm.
More than that, so this patient, I think why she is not responding is because her roots are so much enlarged that the space in the spinal cord, the area there also is actually totally filled with the tumorous enlargement. If you see we have not shown those cuts. If you see the cervical enlargement, it is like bulbous, like an epidermoid with candle guttering appearance. So it is
Nice.
like that.
And eventually they have secondary axonal damage also.
They
So
have.
once they have significant axonal damage is developed, then it is difficult to respond to the treatment also later on. Yeah.
There is a question, Dr. Itoshri. Neurofacin antibodies testing will be useful in this patient?
Uh, Personally, I don't I don't know how it will be. I mean, neurofascian with cervical or lumbosacral roots enlargement, I did not find any case reports. But as far as any CIDP is concerned, it neurofascian usually they respond to like higher therapies. She has responded even to steroid and azathioprine in the beginning. She had achieved baseline. So I think if you people are sending neurofashion more and if you have more experience, we send to we have sent for few patients, but most of the patient has come positive for 2 to 3 antibodies together. Like neurofashion is also positive, sulfatide is also positive, MAG is also positive. So we were not able to characterize those patients how what is the antibody which was contributing to the presentation of CIDP.
Yeah, it is confusing, right?
Yeah.
There is one question of CD59. I am not aware.
CD59.
59 deficiency, was it checked?
No, sir. I have to read about it. I not.
Yeah, I'm also not aware what that is.
I'll check.
Yep. I think questions are all over. Anybody has any other questions?
I think for after a long time we have finished on time.
Finish on time. Yes,
Yes.
just 10 minutes past.
As PG has a reputation of CPCs finishing on time. Okay, so let's starting on time and finishing on time.
Yes.
Kept it short actually.
Yeah, no,
It
it's
was
good. It's good.
excellent. It was so interesting, and
And both
so
cases
nice.
were really interesting. So
Very
it's
interesting. It's so many. This short.
second case you should send it as a neuro image to somewhere.
Yeah, I have been telling
Yeah,
Tanya that since last 6 months now she has examined November, so and she has to submit thesis on June 30th. I don't know if she's submitting on.
Yeah, I mean, how much time will it take to send a neuro image?
For you, only 15 minutes. For
Yeah,
us,
so it should not take much time. Sure.
fine. Then should we close, Vishnu?
Yeah.
so I would
Thank-
just like to thank both of you and the team of IAN Neuromuscular Subsection for inviting us to present in this webinar. And thank you everyone in the attendees part for watching the webinar. Thank
And
you.
thank you to both of you and both you and both your residents. It was an excellent presentation. It was very structured format and it was a very excellent presentation. And most importantly, I would like to invite all of you. All of you should attend our first in-person meeting in September. Dr. Ragesh Singh is hosting it in Pune, in Mumbai. So please, all of you, please attend. This is our subsection's first ever in-person meeting, and all people interested in neuromuscular field should come and join us.
Yes. Thank you so much, Dr. Ritushri, and your department. Excellent cases. And as Vishnu said, myself and Vishnu are doing this subsection meeting, and all are truly invited. Brochure will come now very quickly, and we look forward to that. Thank you so much.
Thank
Thank
you.
you.
Thanks, sir.
Thank you. Bye bye.